what's ahead for increasing equity and reducing barriers related to the opioid epidemic. Healthcare Access Maryland is a nonprofit. We are located in downtown Baltimore. However, we are a state entity that helps individuals enroll in health insurance, navigate the healthcare system, and then address very complex system navigation issues, as well as addressing social determinants of health. We serve approximately 90,000 to 100,000 individuals a year, and we have over 250 staff across the state. So we are excited to host today, and we thank our sponsors, our series sponsors, TriBridge Partners, Kaiser Permanente, and Window Nation, as well as today's session sponsors, Waldron Strategies, Turk House, and the Lord Baltimore Hotel. This event free to you today. So participants will be muted throughout the conversation. So if you have questions, please feel free to add them in the chat, and we'll get to you as we go through. We are going to just set the stage a little bit with a poll question. So I'm going to see if we can get Jordan and or Caitlin in the background there. To do our poll question today. I don't know, we're having some technology issues. Our computers didn't have coffee. All right, we're working on it. The other way to do it is if we can't get the poll, is we'll have people raise their hand. So while we're waiting for Jordan to do the poll, I'm going to go ahead and do the panel introductions. So I'm going to have each panelist will have 2 to 3 minutes to introduce themselves, their name, their title, and their organization. So if you could just keep within that 2 to 3 minutes, I'm going to kick it off with Sadie Smith. Good morning, Sadie.
Good afternoon, Tracy, and thank you. Hello, everyone. I'm Sadie Smith, and I'm so excited to be here with you today. I am the Chief Program Officer for Behavioral Health at Mosaic Group. We are a small consulting firm based out of Towson, Maryland, but we do work nationally in community health and behavioral health, more specifically around substance use. And so we have worked across the state of Maryland in a variety of healthcare settings, including hospitals, primary care practices, detention centers, school-based health centers, college health centers, really helping our healthcare providers identify and respond to patients with risky substance use behavior. And so we've been working to combat the opioid epidemic since 2006, and I'm excited to be here to talk with you about it today.
Thank you, Sadie. And I am also going to kick it over to Joshua Shetterly.
Good afternoon, everybody. Thank you for all being here. Thank you for having me. So I'm Joshua Shetterly. I am the OSOP coach at MedStar Franklin Square Medical Center. I've been doing this role since February of this year, but I've been employed at the hospital for the last 10 years. I come to this field of work. I lost my younger brother to a heroin overdose 7 years ago, and since then, with the and I have a sister in active addiction. So since then, it's just been my passion to really, help those really struggling and try to find a better path in life. So, and not only do I work with the hospital here as the OSOP coach, but outside of the hospital, I do a multitude of work within the harm reduction arena and also the homelessness organization. And then one other thing that also pertains to this work is I help facilitate a meeting called GRASP, so Grief Recovery After Substance Passing. So it just is a safe space for those who have lost loved ones to overdoses, to just come together and be together and to support each other in their time of need. So thank you all again for having me, and I'm excited to be here.
Thanks, Josh. We appreciate it. And our third panelist for today is Stacey Jefferson.
Hello, everyone, and I'm also really excited to be here with you all today. I'm Stacey Jefferson. I'm the Director of Policy and Stakeholder Engagement at Behavioral Health System Baltimore. We also refer to as BHSB. We are a nonprofit organization that oversees the public services for mental health and substance use disorder for Baltimore City. I also like to let folks know that this work is deeply personal to me. I lost 2 family members within 2 years of each other of overdose from opioids. And I also have family members who are actively in recovery. And so, again, I'm excited to have this conversation with you all today. I'm ready to get started.
Thank you. So of course, as they always do happen, our poll is not working, but I'm going to ask if you can see on the bottom of your screen, it says there's a little emoji item that says reactions. You can see that our poll question is, do you personally know someone who is living with a substance use disorder and or in recovery? So if you could, you see your little reaction button, push the heart button as I have done, or any of the other emojis that you choose to use. And you can see that even if you scroll to page 2, there are people that have been either impacted, affected, or impacted by substance use disorder and or in recovery. So it does impact many of us. It personally impacts me. I have a family member in active recovery for many, many years. Actually, 2 family members in active recovery. So I'm going to go ahead and get started, and I'm going to pass this question out to the entire panel to kick us off, and then we'll start to get into some more specifics. So give us your thoughts on the state of the opioid epidemic in Maryland. What are you seeing from where you sit? Sadie, I'm going to start with you.
Thanks. So I think this is a little bit of a tricky question because there's so many levels of views. And however, what I will say is, having worked a large majority of my career in Baltimore City, but now working more broadly across the state, I think in terms of the opioid epidemic, I do see it continue to rise in terms of the severity and occurrence of opioid-related disorders and complications. And I think what we're starting to see is areas across the state that historically had avoided, if you will, the opioid crisis, sort of as we see nationally as well, really start to feel the impact of the prevalence of opioids. And of course, with the reintroduction of illicit fentanyl several years ago now, our overdose rates continue to rise. About 2 years ago, pre-COVID, I was describing to people that we thought we were at the top of the bell curve, and maybe we were going to start to see a decrease in opioid-related overdoses, ED visits, inpatient admissions. And then, of course, with the COVID-19 pandemic, that is not what we're seeing. We're continuing to see actually significant increases in opioid-related overdose deaths, initiation of any substance use across multiple patient populations. And so I think we're in a tough spot, and there is work to be done.
Josh or Stacy, any comments on that question?
So I would say that we are taking great steps to try to reverse what we were, where we were previously at. But unfortunately, we have a whole lot of work to continue to do in order to try to get ahead again of this again. So.
I agree with both of my colleagues said. We definitely are at a point where we have taken great strides in Maryland to try to turn the tide, but unfortunately we still do have a lot of work to do. And COVID had a great impact on that. One thing just to add, perspective to that, the number of overdose deaths in Maryland in 2020 increased by 16.6%. And that is not what we had hoped to see. And so, it increased from 2019. And so, we really still need to think of other innovative approaches to really help to turn the tide.
Agreed. And those are the overdose deaths. And so that's not even speaking to non-fatal overdoses that we are also seeing on the rise. So Stacey, I'm going to stay with you. There is a negative stigma that continues to surround substance use disorders that you don't see with other chronic health conditions like diabetes, like heart disease. How can we change that perception?
So first, we need to really acknowledge the harmful effects of stigma. Stigma really creates an environment where of shame and fear and hopelessness, and it really prevents people from reaching out for support. Also, I'd be remiss if I didn't mention that stigma around substance use disorder has also been especially prevalent and harmful for communities of color. The response is often to demonize and to punish instead of, thinking that treatment is possible. But we can change the narrative, and really our actions and our words make a difference. And so we need to learn to spread compassion and not judgment, and meet people where they are. But one thing I've heard in also the harm reduction space is not just meeting people where they are, but not leaving them there. And language matters a lot as well. And so that is something that we can actually change as an individual. And so an example is some common words that we use culturally is addict. Instead of referring to a person with a substance use disorder. By saying a person with a substance use disorder, you're really acknowledging the fact that this is a chronic health disorder, and not, labeling them as this is who they are as a person. Words like dirty and clean. Dirty when you're referring to like a positive drug urine test. Clean when really we should be using words like abstinent from drug use, and saying former addict instead of a person in recovery. And then also just one of the things, even when we're talking about treatment around substance use disorder, and we're thinking about medication as treatment, we treat it very differently from other chronic health disorders, and we often it's often referred to as like substitution or just a replacement. You're just using another replacement drug, instead of really referring to it as what it is medicated assisted treatment. That this, just like other chronic health disorders, can be treated through medication. And so those, again, language matters. And one of the big things that we can do as an individual is really be careful of the language that we use that contributes to stigma.
Beautiful comment, Stacey. Thank you. I wanted to see if Josh or Sadie, had anything else to add.
I'll just add that I think Stacey really hit the nail on the head, that it's the foundation of acknowledging, recognizing, and promoting the fact that substance use disorders are chronic health conditions and need to be treated as such. And I think I'm probably preaching to the choir here on this panel discussion, but really equipping yourself with the knowledge around what is a chronic health condition and what qualifies as a health condition, and coming away from some of those terms that Stacey discussed, but also just thinking about like moral deficiency or choice, and really starting to use language that promotes the awareness that this is a health condition that can be treated in a medical framework.
Sadie, you gave a really great example when we talked about a week ago about the great big snowstorm that happened a couple of years ago. Do you want to give that example? It really resonated with me.
Yeah. So when Tracy was preparing us for this panel discussion last week, I recalled a time when I was working in Baltimore City. It was probably 10 years ago now. We had a significant snowstorm. And at the time, I was working in different outpatient treatment programs. So I guess it was probably more than 10 years ago, who were providing Suboxone for patients in an outpatient setting. And we also worked within our department in a lot of methadone programs. And the snowstorm came, dumped, feet and feet of snow. And there was a lot of backlash in the days following because all of the dialysis centers had been plowed out, but the methadone programs had not. And I just remember there being, and I actually went back and looked for the news articles and I couldn't find them, but I remember reading a lot of commentary about how we could, save, clearly patients need their dialysis, clearly patients need their medication for opiate use disorder, and that was not seen or promoted at the time. And I think it just goes to show even then, and I'm not sure it would be different in 2021, that we really need to reframe how we're viewing this and the need for medications as part of therapy, but also just how we're acknowledging those treatment resources in the city.
I'm sure we were feeling the same effects in March of 2020 with COVID and the shutdown of many treatment facilities and individuals needing take-home meds and not even negating the fact that they were losing their ability to even join their outpatient treatment programs until things started getting back up and running. So Sadie, I'm going to stay with you for a minute and talk about how accessible are recovery treatment care services to Marylanders, and how has accessibility been impacted during the pandemic?
Yeah, this might come as a surprise to many, but I feel very fortunate at the number of treatment and recovery resources that are available to Marylanders when compared to other states. I think we have a very robust network of outpatient treatment providers. I think we have appropriate detox centers as it relates to benzo and alcohol detox capacity. I think that we have resources, especially in the greater Baltimore area, but even sort of in the suburbs around the District of Columbia, down in Anne Arundel County, and even in some of the farther stretching counties, that patients can get into care. We don't often hear, so we work through Mosaic Group in over 30 hospitals across the state that have employed peer recovery coaches like Josh to respond to patients with risky substance use behavior, and we'll get into that in a later question. But we don't frequently hear too often that, well, there was nowhere for the patient to go when they're trying to make referrals to treatment. Depending on, of course, the needs of the patient, it could get a little complicated. But I think overall as a state, we actually have pretty decent access to resources. We have a lot of people in recovery. And so I also think just from a recovery support perspective, and I think while we talk about stigma, I also think that there's a positive recovery community across the state. And so people can access those resources and get to know people in recovery, I would say easier than in many other places where we're working, like West Virginia and South Carolina and Kentucky, where they're not as progressive, I would say, in regards to recovery or treatment resources. Clearly, COVID has impacted that, though, in regards to, we've heard a lot around treatment providers, especially those with residential capacity, not being able to accept as many patients or limiting their admissions if there was a COVID outbreak at the center. And so that has definitely impacted our ability to make referrals to those higher levels of care, or even just needing to socially distance. A lot of our outpatient programs went to an online format, as I know a lot of recovery support meetings went to an online format during the pandemic as well. And so I think that clearly had an impact on people's ability to access those services, as well as their engagement in those services. And so I think we're starting to come out of that a little bit, but continuing to see an impact. And on the bright side, though, it did force us all to figure out how to do tele NA meetings and tele doctor's visits and tele groups. And so I think while it was uncomfortable and maybe not the best when we had to go fully to that mode, I think that it did open up opportunities for us to think about how to reach more people in different ways.
Josh, any comments on that?
Yeah, so just to kind of touch base on the accessibility part for how they were impacted during the pandemic, I would say, yes, there was extra accessibility to resources, but unfortunately, some of those patients struggling with substance use disorders were not able to access it due to limitations, whether it would be either like cell phone services or, you know, connection to Wi-Fi and things like that. So that, even though the tools and the resources were there, the pandemic and with those changes kind of brought also a lot of isolation type feelings for patients because they weren't able to physically go into a facility anymore and sit down with somebody and really pour out their needs. You know, sometimes they were limited to a 2-minute phone call because they didn't have many minutes left on their cell phone. So it's accessible, but also it kind of hindered some of their care as well, just, you know, depending on the dynamics of the person.
Absolutely. So I'm going to stay with you, Josh. Do you prefer Josh or Joshua?
Either's fine. I answer to both.
Some people have a preference. So what's the importance of peer support in the recovery process? This is not a new term that it's been around for a really long time, but maybe new to some folks. So talk about the role of peer support.
So I think that's a great question. And so the importance of peer support in the recovery process is so that those struggling with substance use disorders actually feel validated and that they have somebody advocating for them, and it's just somebody to talk to. They can hopefully gain some strength and encouragement knowing that the person that they are speaking with has experienced similar pains, thoughts, and just knowing that they're not alone in their recovery. One of the major important pieces of the peer work is that peers can actually be sympathetic, but also be able to set boundaries and objectives for the person struggling. And then kind of as, you know, as my thoughts went on, I wanted to get some input from other people, and I had went to one of the doctors that I work close with here in the recovery community. And I liked how his viewpoint, because I wanted to see how he thought about actually working with peer recovery specialists in this. And he said, it creates a bridge of empathy for our patients. Respecting someone with a substance use disorder history as a colleague and a peer is a profound experience that does not exist in most healthcare settings. It is immensely powerful to know that our patients can see themselves in the team that is caring for them. So, you know, it just goes to show that that person, even though they're almost in the darkness with their life, you know, right now, it shines just that little bit of light to say like, hey, you did it, I can too, type thing. So it's very beneficial in the recovery process.
And I think we're seeing that as well if you look at those with diagnosis of cancer diagnosis, again, with health conditions, they often pair you with a peer of someone who has had that cancer diagnosis or a new recent diagnosis of some big medical condition. And so it is nice to see it, that it is coming to the community with substance use disorders. Stacey, any comments on where we might find this regarding a reimbursable position financially from the insurance companies?
So one thing about peer services is that we know that peers having reimbursement for peers is important for some of those services, but we're still going to need grant funding for some peer services. That's just reality. And so there was a couple years ago a bill to look at particularly reimbursement through Medicaid for peer services. The state had taken on a process to kind of look at what that would look like in our state. And then we have not moved forward since then. And so there has been a lot of talk, though, about reinvigorating that conversation to really, so that we are able to reimburse those services that can be reimbursed, those peer services, and that process has taken place in some way, but it has stalled a little, but there has been lots of conversations about bringing it back to the forefront.
Well, we would certainly like to see that happen. We're going to move on to harm reduction. which is another term that we often are hearing across the states, and actually in Europe and other international countries, it's been very common, harm reduction. So what does it mean to practice harm reduction, and what resources are available in Maryland to reduce harm and prevent overdose? So those are two questions. It's a big one. Stacy, I'm going to start with you, and then we'll go over to Josh and Sadie.
Okay. So harm reduction is really like a philosophy and set of practices that really assist individuals with being safer. We're talking about safety. And really also at the heart of it is, again, meeting people where they are, but not leaving them there. And so there's like two levels of harm reduction. You have the individual, and then you also have the institutional level. The individual level is really about like changing routines, distributing tools, sharing suggestions. The institutional level is really about, again, changing policies and systems to support safety and decrease violence and marginalization. It's really about like creating safer communities. And so, again, it's about meeting people where they are, avoiding placing judgment, and acknowledging like the significance of any positive change. A lot of times that's really difficult because we want people, oftentimes, especially culturally, we've always wanted to see people in abstinence. And again, as Sadie had mentioned before, like people think recovery looks a certain way. And so people aren't always acknowledging like those small, significant, positive changes that we see in people. And so that's definitely part of harm reduction. And also one thing that also harm reductionists will say is engaging in radical love, just loving someone for who they are. And not, again, going back to not placing judgment. So Maryland does have and has made some strides in really putting in place some resources as far as harm reduction. And so naloxone distribution is probably something that a lot of people know well. One, that's an overdose reversal drug that is distributed. One thing to note is that anyone can go to the pharmacist and get a naloxone prescription. There is what's called an open standing order. So you can just go to the pharmacist without like a written prescription or written document or anything and receive naloxone. Also, there is, also people may know well, is syringe exchange programs, or also may refer to as needle exchange programs that are out throughout the state. And so that's provided safe use supplies to persons, and it's really preventing the spread of HIV or other communicable diseases. And then there's fentanyl testing strips that will help people to really be able to test their drugs. And again, this is important because you being informed as a drug user to know the contents of your drugs is also a harm reduction practice. And so these are a lot of the resources that are already available in Maryland as far as harm reduction.
Thanks, Stacey. I put a link to everybody called Before It's Too Late to identify how to locate naloxone in Maryland. And then there's one even specific for Baltimore City. Josh, thoughts on harm reduction? I know this is your world that you live in every day with clients.
So harm reduction is absolutely necessary because if somebody is not ready for treatment, then harm reduction is, that's their path right now. Because unfortunately, with the world we live in, with this, tainted drug supplies of fentanyl and everything, they only have one other option, and that's death. And you can't come back from death. So, if they're practicing harm reduction, it allows them to, also be able to meet somebody almost at one of their most vulnerable times. And, while they are, even if it's only 5 minutes and they're coming to hurry up and grab a new set of supplies and run out the door, that allows you time to just kind of plant that seed in that crack to be able to grow. Because each time they come and they obtain new supplies and things like that, that's another time just to be able to encourage them to do better. And one thing is like, this is going to get me in my soapbox, but you know, one thing is when people say, oh, you give people needles and you give people fentanyl test strip. Yeah, I do. And I'm not promoting drug use, but I want to be able to come back and say, you know, in 6 months from now, hey, you know, instead of, say if somebody's an IV drug user, right, and they're using IV drugs, the life of fentanyl is shorter than the heroin nowadays. So now they're having to use more, right? So which means more needle pokes in the arm, which means now more chances of infection and blood diseases and, you know, all of that comes with it. So if they're not practicing harm reduction and say 6 months down the road, they want help, now you're treating not only their substance use disorders, but you're also treating their medical conditions, and you know, and it's just growing. So harm reduction is very important, and also it allows you to acknowledge positive steps and changes that that person's making. So, okay, even if they're still using drugs and they decrease just a little bit, great, that's a success. Congratulations. You know, and so that's part of harm reduction, is acknowledging, you know, small little changes in the person just in order to get them where we and they are hopefully potentially wanting to be, I guess you'd say.
Josh, you had a recent example in the ED where you were called down to talk to somebody who was refusing treatment.
Oh yeah, actually 2 weeks ago, had a young gentleman here. When the expert peer went in and was talking to him, he was like, nah, I'm not interested. I don't need help with anything. I'm good. Like, you know, this was just an overdose. I'm good. I don't need help. So I said to the peer, did you mention about fentanyl test strips? And he said, no, but that's a good idea. Let me do it. And like, that young gentleman wanted to have no part of conversations with him about treatment. But as soon as you started talking about fentanyl test strips, he like sat up in the bed and he wanted to learn more. And to me, I felt like he realized that we were there to help him and to, you know, encourage him to get better. And it wasn't like, oh, you need treatment because you're here in the ER for an overdose. Not that that's what we do, but imagine sitting in that bed, you know, and having all these people come in and talk to you about what you just did. But now somebody's coming in and saying, hey, look, I know you're going to go home and use today, so please, you know, use safe. And, you know, just because he has fentanyl test strips, he obviously already knows that he just overdosed on fentanyl. So when you test it, what you want to do is that should tell that person to say, hey, I know there's fentanyl in here. It's not going to be like, whoa, I'm not using that. But that allows them time to be able to say, hey, let's think smarter about this, and, you know, use slower, use less than what you're normally used to using. Shoot away, you know, from the heart. Don't use alone. That's one of my biggest things about harm reduction is, you know, just using alone can be deadly because if there is an emergency, then there's nobody to help you. So there's resources in place, whether it would be phone, apps, or an actual in-person resource. So yeah, so fentanyl test strips is very important because now that gentleman was able to leave here, may not have been where he wanted to be, but he left here on a positive note, that knowing that, you know, what he's going to potentially go do, he can make better decisions. So it was a really good interaction. And thanks for bringing that up.
Yeah, well, it resonated with me because you made that connection with him, and if he unfortunately finds himself back in a situation again where he's in the ER, he is going to have that relationship, or even if he needs to come back and get more test strips, he has that relationship already with the peer support team. And so it's baby steps, right?
Baby steps it is.
It resonated with me. Sadie, any comments on harm reduction? I know several years ago, we did, under Dr. Wen, have a blanket, the health commissioner at the time, a blanket statement related to obtaining naloxone. So any thoughts on harm reduction on your end?
Yeah, I think Stacy and Josh did a great, you know, we're very thorough. I think the only thing I would add is I think harm reduction really starts with empathy. And I don't want to steal Josh's thunder, but when we were in our prep call, he gave an example of, you know, safe injection sites and the pushback that we often hear about allowing people to use safely in a monitored environment, and like slapped me in the face really with his description of bars on how they're, you know, what people are walking into bars and consuming alcohol in a monitored and regulated environment, or walking into liquor stores and purchasing, you know, substances that are monitored by the government and regulated, and you know, and we have rules around it. And so I've shared that with everybody over the last 7 days. And so just really sort of, again, normalizing the conversation and normalizing the behavior a bit without approving it. As Josh said, I'm not approving of your behavior, but I can normalize it so that we can begin to talk about it and really reduce that stigma and start to meet people where they need to be met.
Thank you, Sadie. And actually, so if we think about it, all 44 participants on here have participated in a safe consumption site at some point in their lifetime, I would imagine, whether you went to a bar, because that bartender is trained on how to pour drinks and make sure somebody doesn't get too intoxicated so that way they can leave the bar, you know, at the end of the night. Also, a safe supply of alcohol would be going to the liquor store, that everybody does. So, you know, just because us as a society has that, we need to think about, you know, safe consumption sites for other people who use drugs as well, that do not partake in bars and liquor stores. So think about that next time you think about a safe consumption site, and every 44 people on here have participated in a safe consumption site sometime in your lifetime. Congratulations.
Or at least sat in one.
Yeah.
Yeah, and when we are taking your questions, so there's been a couple that have come through, and at the end, for those that we haven't responded to, we will be sending out a survey at the end. We will also be sending out a summary of today's conversation, and we'll make sure that everyone gets links to data, as well as there's a really great NPR story on safe consumption sites in Vancouver. So we'll make sure everybody gets those as well. So as we move on, I want to talk about interventions and preventions activities. There's lots of words like OSOP and SBIRT being implemented to change the course of addiction. So we need a couple definitions for those not familiar with it. I'll start with Josh and or Sadie. Sadie, you wanted to kick it off, and then we'll.
Yeah, I can start. So you heard Josh reference that he's the OSOP here at MedStar Franklin Square, and OSOP stands for the Overdose Survivors Outreach Program. And this is, excuse me, a hospital-based intervention that was piloted back in 2016, developed by Mosaic Group to really respond to our highest risk patients who are coming into our emergency departments. So at the time, again, overdoses were on the rise. We were working predominantly in Baltimore City, where we saw the opioid use patients coming to our EDs more frequently, getting admitted at higher rates, and also sometimes though leaving and or not being fully receiving of the peer intervention. And so we kept hearing from our peers who were talking to these patients in the ED that they were traumatized, they were upset because they were no longer high, they were leaving ED's AMA after their overdose, and they felt like they weren't really getting through and were missing an opportunity. And so we designed the Overdose Survivors Outreach Program as a model to identify those patients when they come to the emergency department, but then have the capacity to continue to peer coach those patients for longer periods of time. We know that when somebody survives an overdose, they're at much higher likelihood of experiencing a fatal overdose. And typically what the data shows is 1 in 10 people die within a year after having survived an opioid-related overdose. And so from that perspective, we said we have an opportunity to identify these patients. Let's do that through our peer work in the emergency departments, and then connect them with a recovery coach who's community-based, who can continue to do that follow-up. And so at most of the hospitals across Maryland, there is this capacity for peer coaches like Josh to be able to meet with patients in the community following their visit to the ED based on their overdose, to provide recovery support services, harm reduction education, overdose prevention education, and really help them get access to care. the reality being a lot of them at the time of overdose are not emotionally prepared to engage in a conversation about significant change. And that way, connecting them with that recovery coach to work with them over a longer period of time can help them move through the stages of change and really begin to think differently, or at least use in a more safe way to be able to prevent any additional overdoses. I'll just add briefly and then pass it over to you, Josh. SBIRT stands for Screening, Brief Intervention, and Referral to Treatment, SBIRT. It is a evidence-based framework to identify and respond to patients with risky substance use behavior. And so from that perspective, we use it as a foundation of integrating improved behavioral health strategies in a variety of healthcare settings, as I mentioned earlier. So in the hospitals that we've worked in, we are universally screening all patients for any risky substance use behavior to make sure we're identifying those patients who are using marijuana and have a preventative conversation with them, those who are using opioids to discuss harm reduction techniques, offer treatment resources, and also any risky alcohol use patients, because alcohol continues to be the most used substance across the United States. And so we want to make sure we're identifying those patients as well. And so those are just a couple of the interventions that are being done, and those are at a hospital level. But I'll pass it off to Josh to talk a little bit more about what OSOP entails.
So pretty much that, I mean, that was it. How I like to explain the difference between OSOP and SBIRT is I see my patients on a reactive situation. So I'm here reacting to them coming into the hospital or the emergency department after an opiate overdose. So like Sadie had mentioned, sometimes they don't want to speak. Sometimes they don't want to speak to me at all today, but tomorrow when I call them on the phone, they'll be able to, you know, open up more. And that's because of the, you know, traumatic events that they've experienced that day. But the SBIRT peers, you know, they do see people with active substance use disorders as well, but I like to say they also have a proactive approach to the situation because they are potentially getting to those who have not made it that far down the road yet. So for instance, this is kind of goes back to the harm reduction piece of it, but I myself am able to give out fentanyl test strips to my patients after they come in of an overdose. And to me, that shows them, hey, that's just reminding them, hey, that there's stuff in your drugs that you need to be safer and use. So it's a reactive approach to the situation. SBIRT is able to utilize harm reduction in a proactive way. So for instance, my example of it would be, so that person that likes to go out on their boat on the weekends down Boley's Quarters or Annapolis and sniff some cocaine on their boat while they're out in the middle of the Chesapeake Bay or whatever, they could utilize some fentanyl test strips and education just to say, hey, test your stuff before it actually gets to a point where it's, you know, then they're here for an actual overdose. So the interventions and preventions of activities of OSOP and SBIRT are there to help people, either in a proactive way or a reactive way.
Thank you. Thank you for both of those. Two very important initiatives that are happening in many states, but I know across Maryland, especially doing SBIRT in non-traditional settings. So Sadie, can you talk a little bit about where those SBIRT screenings are happening?
Yeah, and so it really varies. In most of our hospital settings, when a patient comes in through triage or when they get bedded in the emergency department and they're getting their nursing assessment, they're being asked typically the audit C, which is 3 questions about their alcohol use. How often do you have a drink containing alcohol? How many drinks do you have on a typical day when you're drinking? And how often do you have 6 or more drinks? Which then allow us to stratify the patient's risk based on those questions, and then asking them about any illicit or recreational drug use or prescription drug misuse. And so, you know, I will put this out there. when women go to a primary care doctor, it doesn't matter if I go to the ED, it doesn't matter if I'm going to my OBGYN, if I'm going to an urgent care, if I'm going to primary care, if I'm going to the eye doctor maybe, I'm always going to get asked when my last menstrual cycle was. because it's a routine part of the provider's understanding of what's going on with my health. It doesn't care if I'm going for a broken finger, they're still going to ask me. And so I like to use that point as, a lot of times individuals or providers or nurses or MAs, as we're working with them to integrate this screening process, they say, well, they feel uncomfortable asking a patient about their substance use, or even then following up with a conversation. And, but it's critically important, and it doesn't faze me anymore, regardless of why I'm at the doctor, when I'm asked those questions, because it's a normal routine part of care. And so we've been working on this SBIRT work in Maryland since 2010, really, 2009, 2010. And our goal is that you're getting asked those questions. And I have friends who text me and say, oh, my doctor asked me the audit questions today. I was like, yes, score, success, because we want to make it a routine part of care. It's an important component for, as we move into that substance use disorder as a chronic health condition, and really acknowledging that, making sure providers and patients acknowledge that my doctor needs to know this about me too. And so we're doing it at college health centers when they're coming in for their annual physicals, maybe for sports visits, or even when they're coming in for any well or sick visits. We're doing it in school-based health offices for middle school and high schools across counties to make sure, again, adolescents are being asked questions about their substance use behavior. We're doing it in detention centers. We know that there's a significant high risk for overdose upon release from any detention. And so we want to make sure we're identifying those patients who do have risky behavior, so we can make sure that we're putting appropriate stopgaps in place upon their departure. And so it's really about recognizing in any healthcare setting how we can normalize that conversation and make sure patients feel comfortable being honest about their consumption and recognizing it as a routine part of their healthcare.
Thanks, Sadie. Right when you said that, it also reminds, you go to the doctor, any doctor, and they ask you all the types of medications that you're on, right? To normalize these questions again. And I remember years and years ago, this is a whole different speaker series topic, but I remember years ago, Sadie and I worked together, and Sadie had a client who was on buprenorphine, who was on Suboxone. This was not a medication that was typically given at that time in the prison system, was not on the formulary, so that this patient was going to go through withdrawal symptoms, and reported that they actually hid their Suboxone in their pants. I don't know if you remember this, Sadie. Hid the Suboxone pills in the hem of their pants so that they could continue taking their Suboxone. Now, of course, I'm not condoning it, but it just went to show that not even Suboxone at that time, this was probably 10, 12 years ago, for medication-assisted treatment, was not even on the formulary in our prison systems. And we are moving in that direction in improving that. So to kind of transition, so I have a very good memory, Sadie, of those stories. But from a policy standpoint, could you discuss legislation in Maryland to create overdose prevention sites, or what we've been calling safe consumption sites, and what benefits and successes have been shown from developing these sites? I'm gonna flip that over to Stacy.
So yes, so there has been legislation put in for about the past, I want to say about 6 or 7 years, to authorize overdose prevention sites or safe consumption sites in the state of Maryland. And so this bill was put in the past session in 2020 as well. And just so everybody has an understanding of what these sites are, they are sites that target high-risk drug users, and they help them access services such as like wound care and additional resources. It allows them to use drugs in a safe place. Again, having access to other resources as well. As Josh mentioned, many people, we have to be realistic, are using drugs, but they are using them in unsafe places, and they are isolated, and they are alone. And we need to continue to find ways to ensure that people are alive to be able to continue their journey. And so this is really what safe consumption sites or overdose prevention sites will allow. And there is a coalition, I would be remiss if I do not mention, the Bridges Coalition, which is a coalition in Baltimore City that continues to advocate for overdose prevention sites and really spearheads the advocacy effort our organization is a part of that coalition with lots of other advocates. And so, again, these sites do exist in around the globe, and there are more than about 150 of these programs that have been established in more than about 60 cities and in about 12 countries. And so they do not currently exist in the United States. However, there has been lots of conversation and movement to establish these sites in various other states. One in particular, Rhode Island, just in this past July, the governor signed a bill into law to authorize a pilot program for safe consumption sites. And so, again, the bill for overdose prevention sites mirrors these sites that we do see around the world. And so a couple of things to highlight about the success, because again, people automatically hear that you are definitely trying to encourage people to use drugs. That is not what we are trying to do. We're trying to keep people safe. But the studies have shown that in these sites that there has not been one fatality, overdose fatality in any of these sites that currently exist. There was also a study of the Canadian facility. I know Tracy had mentioned the NPR story. There's lots of stories and data from particularly Insight, which is a safe consumption site that is located in Vancouver. And in that same study that that shows about the overdose fatalities, it also shows that they found that overdose mortality dropped 35% in the area surrounding the facility. And so not only were people, did it impact people who directly came to the site, it also shows the community impact and how the reduction in overdose fatalities in that community where Insight is located. And then also, these sites really do link people to services. So again, we're meeting people where they are, but not leaving them where they are. And so the same study of the Canadian facility definitely shows that the participants increased detox services, the use of detox services by more than 30%. And so again, we cannot ignore these numbers. These numbers show that these facilities have been successful. And we definitely need to continue this discussion, but really move forward as a state and recognizing that these sites keep people alive and they are another way to get people to access services.
Thank you, Stacy. One of, Baltimore was one of the first entities to have needle exchange programs, and that still exists today. And HCAM participates in those needle exchange vans to help people enroll in health insurance and navigate the healthcare system on those needle exchange vans. And we've done that since 2009, although those needle exchange vans have been around with the City Health Department for a very, very long time, back in the late 90s, early 2000 when they were established. So we talked a lot of today about harm reduction. Oh yeah, go ahead, Josh.
So real quick, I just wanted to touch base about the safe consumption site. So even though we, as Stacey mentioned, we don't have safe consumption sites here in the United States, again, got to think outside of the box. So there have been organizations that have come up with other alternatives that are actually being utilized right now in the United States. There's a phone system called Never Use Alone, and then there's also an app called Brave app, and it's for people who are actively using drugs. A couple weeks ago, I actually became a Brave volunteer just to kind of see what it was about, because again, we've never experienced safe consumption sites here. So I kind of just wanted to be on the phone to see what it was like, while people are actively indulging. And they just share with you their emergency contact information. You don't know who, I don't get their information, but if there was an emergency was to happen, you just literally simply click a button and their information pops up and it connects you with either like Rapid 911 or Northern 911 or Rapid SOS. and that allows you to be able to connect that person to help. So even though there's not a physical safe consumption site for them to go to right now in the United States, there are resources available. And I like to just share it with everybody, because then when the day comes to say we don't have safe consumption sites, well, we can say, well, we've been utilizing these other resources that are like safe consumption sites, so why can't we have a physical standing building for them to go to? So
That's great, Josh. If you could put those in the chat, that would be fantastic. Really helpful for us. Thanks. I muted myself. There are many businesses on the call today, and one of the things we try to focus on are, businesses will say, well, that's not my issue. But if you have an employee, more than one, that's your issue. And so what can workplaces do to support their employees that live with substance use disorders? Sadie, thoughts about it? And of course, obviously, having the conversation at work.
Yeah, I think I have employees who are in recovery and have worked in many institutions who are clearly hiring people in recovery or people with lived experience with substance use disorder. And so one of the things we really try to do is create a recovery positive environment. And so that includes a lot of the stuff Stacy mentioned earlier about reducing of stigma, just in terms of changing the language and making sure that your organization is aware of sort of the appropriate terminology to be using in your workplace to make sure that that individual doesn't feel stigmatized. I think the reality is also we often find that many more people are in recovery than are telling you they're in recovery. And so you likely do have employees who with lived experience with substance use disorder. And so really making sure you're aware, even if you're not intentionally hiring that workforce to be a recovery positive environment. I think also acknowledging things like Recovery Month, understanding sort of important dates for that person in recovery, or even modifying schedules based on their recovery needs. So if they have a home group, making sure you're aware of that and trying to accommodate schedules as best as possible as you would for any other employee population. And those would be sort of some of the major components. I think from a supervisory perspective, it's really important to be aware of the amount of self-care that you should promote for all your employees, but especially I think for our individuals who are in recovery. I think when there are triggering events or other things that might happen in life, really taking time to acknowledge and give space to that individual to think about what's the next best thing and the next right thing that you can help them do.
Thanks, Sadie. We've talked a lot about people impacted by substance use disorders, those that are in recovery, those that are supporting family members in recovery. And I know one of the things that we really wanted to walk away with from today was that recovery is possible. So I wanted to send it over to Josh and Stacy to talk about the probability of recovery from substance use disorders, and is there hope for recovery for all people affected by substance use disorders for today? Kind of wrapping us up.
my answer, honestly, I'd say no. Because rock bottom is the grave, and those being affected by substance use disorders are being poisoned by the illicit drug supply. So, but 92% of all opioid deaths last year were laced with fentanyl. And honestly, a person is in recovery when they say they are. Another thing is, I have a bullet point that says, like many diseases of addiction cannot be cured, only forced into remission by the individual. Recovery is no cookie cutter model, and the desire for recovery comes from within the individual. Someone may recover from the current situation, but the lasting effects are lifelong, of the event are lifelong. And I think SAMHSA's definition on their website sums it up best. And literally from their website, it says that recovery is a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. So, it doesn't say nothing specifically about abstinence or anything. It's just, kind of pointing them in that right direction to make a better life for themselves. Doesn't have to say stop using, but if you decrease your use and use safer and smarter, then that's progress. And that could be part of their recovery. So that's my ending point to it.
I like the term remission, because that really, again, in my mind, really talks about the opportunities that individuals have, very similar to chronic conditions, right? Somebody who's diabetic doesn't necessarily mean because today they're not diabetic means that they won't be diabetic again if they
Right.
40 pounds and start eating all this sugar again. So very similar type analogies there. Stacy?
So I really encourage us to think about this a little differently. And so I agree with Josh. We should probably ask, can we live in a world where people live healthy, happy lives and are able to access the wide array of services, no matter where they are, including Medicaid-assisted treatment, when they're ready with minimal barriers? And again, just to reiterate what Josh had already mentioned, recovery looks different for individuals, and it's not a linear process. Again, remission is a much better term to think about. And, can we get to a point where we really view substance use disorder like we do other chronic health conditions, and provide services and supports in the same way that we provide for other chronic health conditions? And that's really how I, would rather think about that term, because when we think about it in a way of whether or not people will recover, or will we ever get to a point where everyone would have been recovered, we also don't take into account harm reduction. And really thinking about the fact that, again, we need to meet people where they are, because some people are not ready. And we can't leave them there. And how do we also include them in this process as well?
Absolutely. We talked a lot today about so many different areas, and I want to allow each and every one of our panelists to have an opportunity about a takeaway that our audience should walk away with. And so Sadie, I want to make sure you have an opportunity for that takeaway as well.
Yeah, so thank you everybody for your time and patience as you listened to us all share our thoughts. I think one takeaway is that I really think, so there's a small billboard that I pass on my way home when I'm working downtown and driving through West Baltimore that says, "Dear HIV, we didn't give up, signed Science." And it resonates with me every time, because as I had mentioned to the panel last week, if you had told us in the early 90s that we were going to be able to say that HIV is non-transferable and non-detectable, I'm not sure any of us would have really believed it. And so I have hope that we are going to continue to make incredible strides as long as we keep this at a priority and really think through, from stigma and changing our language to medical advancements, and really approaching this from a chronic disease perspective, everything that we can do. And it starts with us and changing our language and sharing our stories and empathizing and really connecting with the people near us.
Thank you, Sadie. And that billboard is right by the train station, right on St. Paul, and right over a gas station, I think. If it's
Well,
that
and the one I see is it's on a corner store. It's like a smaller billboard on the door of a deserted corner store, actually. But
I see it right when you get off at St. Paul. There's one. Go on your way downtown. So thank you for that. And I'd love to see that billboard. Recovery is possible, and we haven't forgotten about you. Josh, some takeaways?
So my takeaway would be, well, thank you all, first of all, for coming and, spending time with us and able to listen to us. Hopefully you learned something from us three, but I think the biggest takeaway is that if everybody in this meeting here could just take something they learned from some of us panelists and share it with others, just spread the word, and that'll be your takeaway. So that way you can keep that, keep the momentum building and keep the knowledge flowing to others and let them know that, recovery is possible, but recovery also looks different on everybody. So that would be my
Absolutely.
takeaway. Share it with
Thanks.
others for the rest of your day.
Thanks, Josh. Stacy, any other takeaways for today?
I agree with what's been said, but then also I just want to reiterate that substance use disorder is a chronic health condition, and we need to start treating it as such. And if you don't leave with anything else, it is with that understanding that we'll get to the point where we are treating substance use disorder, and we will show that we haven't given up.
Absolutely. So I think Sadie said it as empathy, showing empathy to those dealing with substance use disorders. And if that's what you can walk away with from today, I think then we have been successful here. Just a quick closing and some thank yous to, again, our panelists, Sadie Smith, Josh Shetterly, and Stacy Jefferson for enlightening us today on the opioid epidemic. And we have a long journey to go. I know that. We'll continue to work really hard as HCAM continues to provide care coordination to those in substance use treatment programs across Baltimore City, Baltimore County, and Anne Arundel counties. And we are a partner on the Here to Help line to connect individuals to treatment, both substance use and mental health. And so we will continue to partner on that. I want to thank our sponsors again for supporting today's event. TriBridge Partners, Kaiser Permanente, and Window Nation as our series sponsors, and our session sponsors, Waldron Strategies, Turk House, and the Lord Baltimore Hotel. There will be a link in the chat for a survey to complete on today's events. Just giving us our feedback that helps guide future conversations. We apologize for the technical difficulties that happened earlier this morning. So we apologize for that. Hopefully you did get some networking in and were able to connect with others. And we will be sending out a follow-up email as well with a lot of information that we provided today, because there was a lot and people had some questions just on data and resources and links. We'll make sure you get those. And as one final follow-up, this is a 4-part series. So this is the second of 4. We will be having 2 in the spring. And if you've registered for today, you will get our information in the springtime about our 2 speaker series events that will be happening. But we are also having a Giving Tuesday event on November 30th. And we would love for you to join us. So we'll make sure that you get a save the date on, not June, November 30th. I'm just trying to funnel my inner warmth because I'm really a summer person and it's getting into winter already. So that's why I'm still in the June month. November 30th will be our Giving Tuesday event. And so we'll make sure that everybody gets a save the date so you can join us. I just want to thank Josh, Sadie, and Stacy for joining us today. Thank you, everyone. If you have other questions, please feel free to put them in the chat before you leave us today. And thank you for your time.